Welcome to the Clinical Cousins YouTube channel, and this video is going to be on immune thrombocytopenia, or ITP. Now, it may come up on tests as it was formerly called immune thrombocytopenic purpura or idiopathic thrombocytopenic purpura. It no longer has this name, as you don't always find purpura or petechial hemorrhaging with the disorder itself. It's simply a low platelet count. It also causes large platelets. It's one of the disorders that causes large platelets, which we'll discuss here in a minute. So first off, we need to discuss what are the steps of hemostasis. Well, the first step that happens is our body actually causes vasoconstriction to the area where we'll have a bleed. The second thing that happens is the first part of primary hemostasis, and that's the formation of a platelet plug when the endothelial wall gets damaged here, which we'll go into that in a little more depth in 1 second. The next thing that happens is we have activation of our clotting factors, or secondary hemostasis occurs. These are the things that affect our PTT levels. They're involved with fibrin production and clot formation. The next thing that happens, well, then eventually the clot is broken up by our body's natural tissue plasmin, or TPA, and then the area is repaired. So in this case, we're dealing with the thrombocytopenia, so we're dealing with a low platelet count. So what do platelets do, and what's their job in primary hemostasis? Well, the purpose of primary hemostasis is to initially plug this area with platelets. How does that happen? Well, it happens in 3 steps. We have platelet adhesion, which is when this area's endothelial wall is damaged and it comes in contact with the area beneath the endothelium that contains von Willebrand factor. This connects with the GP1B receptor site that's on the platelet. So when the platelet and the von Willebrand factor come in contact, they adhere, and that's called adhesion. The second part that happens is platelet activation. When these two complexes come together, we get an activation or release of adenosine diphosphate, ADP. We also get a release of thromboxane, which is one of the things that aspirin blocks. So this ADP release causes expression on the platelet, or for these little receptor sites to come out that are called GP2B3A receptor sites. Now, when those sites come out, the next part can happen, which is platelet aggregation. ADP and thromboxane, they also signal for more platelets to come, so that's why we call it the activation process. We also have our granules. They'll start releasing our alpha and dense granules. We'll start releasing their contents. The next part is platelet aggregation. So we have this GP1B site here with von Willebrand factor that have formed a complex and called the platelet to adhere. We've had a release of ADP, thromboxane. We've had an expression, or these GP2B3A receptor sites to come out. And now what we have is platelets start aggregating together and connecting at these sites through fibrinogen as well. So this is the normal process that occurs when we in primary hemostasis. And what happens in immune thrombocytopenia is we have an antibody that actually works against one of these processes. It happens to work against platelet aggregation. So there's an IgG antibody, if we remember that's the little one. IgM's the bigger one. We also have IgA, but IgG is a small one, so it can cross into the placental blood or the blood of the baby as well. Now, as these antibodies are formed, they actually fight here at the GP2B3A receptor site, and they don't allow adhesion of the platelet. So as a platelet comes along, it forms a pseudopod, it gets really big, it connects here with this von Willebrand factor, but then it can't aggregate. So these platelets end up getting destroyed. We end up with lower platelet counts, and we end up in thrombocytopenia. So what do we do in these cases? What does problems with primary hemostasis, what will we see in these patients? Well, in primary hemostasis, problems with this, we're going to see problems with platelet plug formation. So we will see increased bleeding times because we'll have less platelets there. We're going to see a decrease in our platelet count, which is obvious even from the name. So we're going to have a low platelet count, increased bleeding times. Now, problems with primary hemostasis cause problems with superficial mucocutaneous bleeding. So in problems with your secondary clotting factors or your secondary hemostasis, you have deep anatomical bleeding, you have bleeding in the joints, you have rebleeding, bleeds that reopen as we see in DIC. Well, with primary hemostasis problems, we get more superficial bleeding. That's where it gets the name Purpura, which we don't always have to have. So in it, we'll have those petechial hemorrhages that look like little freckles come up. We'll have purpura that's non-palpable. Now that's important because if you see a little purple area there of bruising, that's a little bit bigger than your petechia spots, but it's not big enough to be ecchymosis because it sort of goes in order of getting bigger. And you feel of them, they won't be raised. Now that's important because if you see an area of purpura that's non-blanchable, purpura is always non-blanchable, so you try to blanch it, it doesn't blanch. If it does blanch, maybe it's an allergic reaction or something. If it doesn't blanch, like, okay, that's purpura, and then you feel over that and it's not raised, well, that can be found in this condition. Raised purpura is seen in conditions of vasculitis, where the vascular area in that area is actually inflamed, and things like Henoch-Schönlein purpura. But in the case of this, we're going to see non-palpable, non-blanchable purpura. Now, who will this disease affect with low platelet count? So we may have some bleeding with these, but most of the time we don't. We most of the time have normal red blood cell counts, normal white blood cell counts. The only problem we see is a low platelet count, which a lot of times the docs will say, or providers will say, I need, since you did that in an EDTA containing tube, a purple tube, maybe they need you to put that in a blue one with sodium citrate. And the reason is sometimes EDTA can cause clumping of platelets and give you a false or a pseudo thrombocytopenia and it not be real. It can cause these little mini satellites to form. So they may have you do that. So you find out it's a real thrombocytopenia, but the patient doesn't have a lot of bleeding. Their RBCs are fine. Their white count's fine. Maybe they have petechia and purpura. Maybe they don't even have that. Maybe they have no symptoms, which can come up with this. So who is the group that this will affect? Well, in acute ITP, this is more prominent and usually in children, and it's usually following like a viral illness. So this will come up. It's usually self-limiting. It goes away on its own. Now, the chronic ITP is usually diagnosed in young pregnant ladies. Now, is it because they're pregnant? No, it's because usually they have all kinds of blood tests ran on them at the time. And because of all the tests that are ran, they end up finding out, hey, you also happen to have a low platelet count. Now, this can lead to bleeding and can lead to problems when you have severely low platelet counts. We're talking less than like 50,000. When we start getting in that range, we can have problems with bleeding. But usually with this, it just happens to be found on the side. Now, if it does have problems, they'll do a peripheral smear. One of the things we're going to find in this is they're going to have large platelets. They're going to have a low platelet count, and they're going to have, because of that, increased bleeding times. Now, another thing to the chronic form is it relapses. It tends to come and go and come and go. It can be mild, it can go away. It can be severe and it can go away, but it tends to come and go a lot. That's why it's called the relapsing type, whereas in children, it usually doesn't come up back again. It's usually self-limited. Again, the cause is Igg antibodies directed against these GP2B3A receptors, which cause platelets not to be able to aggregate. So we just get big platelets that are useless and few of them. Now, treatment in this is going to be no symptoms, no problem. Now, patients don't like to hear that you're going to do nothing. So when the physician or provider comes in and says they're going to do nothing, what we call this period of watchful waiting. It means they'll come back to get follow-up. And, we don't treat numbers, we treat patients. If it is causing issues, sometimes they'll give steroids, because what do steroids do? They slow down your immune system. The immune system is what's sort of attacking in this case. Another thing they can do is they can give IVIG, which is another immunoglobulin G. And why would you do that? Well, if your body's busy fighting, or macrophages are busy fighting with another G to attack it, they have less time to attack your platelets, so that can help them to rise up. And then there's also this anti-D they can give in people who are Rh, rhesus factor positive. And why would you give this? Well, it actually induces a small amount of hemolysis, and in hemolysis, if your body's busy cleaning up the mess from that, it's also not busy killing platelets out. So that's some of the methods that they can use there. Now, in extreme cases, these patients, or your patient may be prescribed to receive platelet transfusion. Unlike in TTP and some of those other conditions where you wouldn't want to give platelet transfusions, in this, they can be given if it's severe. Other thing of note is the difference between ITP and TTP. In TTP, you have schistocytes or hemolysis has taken place, microangiopathic hemolysis has taken place. So when that happens, you get those schistocytes on the smear. On this one, there are no schistocytes. That's another thing that's different. But outside of platelet transfusion, they may give some of these monoclonal antibody drugs like rituximab. This actually fights CD20. And the reason that's important is it attacks some of those B cells that make those plasma B cells that release all the antibodies. So that way your platelet count can go up. And drugs like rometaplastin, which I can never pronounce these two, they attack that receptor site and cause you to increase your production of thrombocytes, sort of like erythropoietin does. Thrombopoietin actually increases the amount of platelets you make. So these are other things that may be given. Now, in extreme cases, usually not in children because they need their spleen, because spleens do have a function, and that's helping us to fight off these encapsulated bacterias. They may get splenectomies in adults with frequent recurring severe chronic ITP. What are the things we need to look for in a patient who gets a splenectomy? Well, first, we need to understand why they get a splenectomy. Like I said, splenectomy is a place that platelets like to hide. So if you take the spleen out, the platelets don't have a place they can hang out as much, so then they're just put out into the circulation, and that by itself raises your platelet counts. Another reason is the spleen also is used with the splenic macrophages. They actually destroy the platelets, so there's another reason, less destruction of them. Third reason is the IgG that's directed against these receptor sites. The plasma cells for those hang out in the spleen. So you remove the spleen, you remove where the antibodies are being produced by those plasma B cells. Now, before someone has a splenectomy, we always want to make sure that we ask the physician if they want to go ahead and have them vaccinated beforehand, and to give them antibiotics against encapsulated bacteria. What's our most common encapsulated bacteria we deal with? That can be found in a little mnemonic SHIN. SHIN stands for strep pneumoniae, which isn't to be confused with strep throat. It's one of the most common causes of pneumonia, especially in smokers as they get older. It's one of the things we give the pneumonia vac for. It's a pneumonia vaccine for a bunch of types of strep. So the capsule that's around strep, whether it's 15 or 21 different types, isn't for 15 or 21 different types of bacteria. It's all for the strep pneumoniae, which is encapsulated in maybe 15 to 21 different types of capsules to hide itself from our immune system. So when we train the body to recognize those capsules, the body can then attack and kill these bacteria. The other one is Haemophilus influenza and Neisseria meningitis. So these three are the most common bacteria that are encapsulated, that are fought off by your spleen. So we have vaccinations for these, so usually we go ahead and give those, and that will be the reason we give those. So again, this is ITP, immune thrombocytopenia, formerly known as immune thrombocytopenic purpura or idiopathic thrombocytopenic purpura. This is how it works. This is the treatments we use, and this is why we use those treatments, and why we need to vaccinate if someone's getting ready to get a splenectomy. I hope you liked our content. If you would, hit like and subscribe.